We're going to talk about ganglia. Ganglia are one of the most common problems hand surgeons see in all age groups, actually. Ganglia, if this represents a joint, and this is the capsule, the synovium inside the capsule of the joint is under pressure, either from a ligament tear, what the patient does, activities, and it will form a little herniation of the synovium that comes through that capsule. And then what it does is grow. And the way it grows is the synovium under pressure in the synovial fluid inside the joint comes out and fills the bulge of the herniation, if you will. And if I expand that, it gradually grows the ball on a little stalk, which is the root. And the way it grows is the synovial fluid gets into the ganglion, the water leaves the ganglion, but the little connecting root, if you will, is too small for the jelly-like thicker fluid that's now left in the ganglion to go back into the joint. So that the ganglion grows by virtue of the fact that activity produces increased pressure, the synovial fluid goes into the ganglion loses water, the material in the ganglion can't get back into the joint, and the ganglion gets bigger. There are several fairly classic ganglia. If this is the scaphoid and this is the lunate, this is the classic dorsal wrist ganglia that occurs about in this area on the back of the hand. And that's secondary to the pressure, usually from the very common phenomena of the scaphoid's anatomy. The scaphoid wants to escape from beneath the capitate. We all fall and produce small tears, usually volarly. The scaphoid produces an increased pressure in the joint because of that skidding out of the way, if you will, under too much activity pressure. So the dorsal wrist ganglia is fairly common. If you turn the hand over, we get the volar wrist ganglia, and they come in two varieties. A volar wrist ganglia, this is the scaphoid from the front, this is the radius, and this is the trapezium. And degenerative arthritis with some osteophytes that form on the scaphoid and the trapezium up here are the etiology of a ganglion that comes out from the scaphoid trapezium joint. Now the flexor carpi radialis lies right across the front. And the flexor carpi radialis serves as a conduit. And the ganglion herniates, just as it does here. It herniates from the synovial space, and then it travels and its root grows and it comes along the flexor carpi radialis, and the ball of the ganglion will be related to one side or the other of the flexor carpi radialis. And these are the easier ganglions to attack surgically. The other ganglion comes most often from this area of the scaphoid radial joint, and the ganglion comes out here. Now the problem is the radial artery lies just offside of in fact it's heading around dorsally in this area, and the ganglion finds its way along the radial artery and often encompasses the radial artery, wrapping around it. These can be huge. These don't get as big, but the ganglion that comes out of the radial scaphoid joint can grow down into the space around the artery, and often this is a very large and extremely difficult ganglion to get out without damaging the artery or the veins that run with it. There is a ganglion that occurs, this is the flexor sheath, and that's the flexor tendon running through it, and this is the A1 pulley. Then there's a little bit of a space, and then the sheath continues, and that's the A2 pulley. And this is the area that little ganglia occur that are called flexor sheath ganglia. They come out of the front of the flexor of the fibroosseous sheath, usually at the junction of the A1, A2 pulley. If they come out dead center, right on the front, they drive the patient crazy. This ganglion, just at 2 or 3 millimeters in diameter or even smaller, lying directly on the front of the sheath, bothers the patient with tools, steering wheels, mops, any kind of activity. If the ganglion herniates off to the side, so that the ganglion is not on the front of the sheath, the patient tolerates it often quite well. Get along with it, doesn't bother, they know it's there, not an issue. This is often associated with a stenosing tenosynovitis or trigger finger problem because of the problems in the tunnel where the A1 pulley expands. If a ganglion, back here for just a second, if the ganglion occurs as with a carpal boss, and that's the other common area, capitate, trapezoid, index metacarpal, middle metacarpal. This is the ostyloidium on the middle, and you get a localized degenerative arthritis where these four bones meet, secondary to usually bony abnormality with which the patient was born. And it develops a ganglion. These very seldom form any kind of a root and are found in different areas. The ganglion is almost always applied right to the carpal boss area. The last one we mention is a mucoid tumor, which occurs at the distal joint. If this is the distal joint and it develops a little bit of arthritis, this is the extensor tendon inserting here. These ganglia occur on either side of the extensor tendon. So that a mucoid tumor or distal joint ganglia will occur right on either side, just at the joint or proximal or distal to it. If that little ganglia rests on the germinal tissue that produces the nail, it will produce a groove in the nail. And you can determine the age of the ganglion, or at least say that it's been there for 9 months to a year, if the little groove in the nail comes all the way to the tip. You can also read the history of the ganglion in the nail. If the ganglion is ruptured by a well-meaning physician or ruptures under contact, there'll be a flattening and then the groove will reform as the mucoid tumor recurs. This kind of ganglion always requires a resection of the ganglion, resection of the root, and a little modified arthroplasty where you take the osteophytes off the middle and distal phalanges, and they're almost always associated with it. So that's our rundown of ganglia. We have them at the distal joint, we call them mucoid tumors. At the A1, A2 pulley, flexor sheath ganglia. The volar wrist ganglia occur along the flexor carpi radialis, small and spherical, or large and more to the radial side, coming from the radial scaphoid joint involving the radial artery, and of course the classic that comes from the scapholunate joint dorsally and has a root and can vary its position quite a bit on the back of the hand. Thank you.